Good morning, Peter Goertz. I'm a psychiatrist. Each patient is different. And to me, that's a heartwarming thing. No matter how many protocols and guidelines in medicine we create, each patient is still going to be different. So last week, I saw a patient who came into the emergency room with an alcohol level, serum alcohol level of over 400, which is usually the legal limit is around 100. So quite high. And I saw the patient maybe 2 hours after she came into the emergency room. So probably the level was still quite high then. Now, some psychiatrists will say, do not see an emergency room patient unless the serum alcohol level is below 100. But over the years, I've tended to be flexible because some patients, even with a very high level, if they're heavy drinkers chronically, they're cognitively intact at that level and can give a good interview. So I tend to be flexible so the patient doesn't have to wait for hours and hours in the emergency room. And this patient actually that I saw last week was cognitively fully intact at that alcohol level. And on top of that, she'd been agitated in the emergency room and received an injection, a sedating injection in the emergency room before I saw her, and she was still intact cognitively. So pretty amazing. So again, a lot of people would have been in a deep, deep sleep at that point, but she was far from it. So that's one example of people being very different, and we want to keep an open mind. That's really pretty much the bottom line. We want to keep an open mind. We're dealing with human beings. We're not dealing with people who necessarily fit into protocols or guidelines. Another example, I'll give you a few examples. Another example is a patient who has been able to get on and off Klonopin back and forth. Klonopin is a benzodiazepine in the Valium family, and she's done that without a problem. On and off. Whenever she needs it for a period, she takes it. When not, she stops taking it. For other patients, that can be very difficult to do. Klonopin can be a very difficult drug to get off of. Xanax tends to be even more difficult to get off of. So we want to look at the DSM guidelines with flexibility, and actually the DSM itself tells you to be flexible. So in that sense, it knows about itself, the DSM. And it knows that individuals are individual. Another example of a patient is a patient who was talking about a UFO, and we see many delusional patients in psychiatry, so it's entirely possible for a patient to be delusional. However, this particular patient did not come across at all as delusional to me, and in fact, she didn't really want to talk about that subject, but gradually she started talking a little bit about her, and she'd had quite a bit of distress from that experience. So again, we want to keep an open mind. You may or may not believe that UFOs exist, but for this particular patient, it's something I want to keep an open mind about. It may well be that she saw a UFO. So another patient an older patient who was using heroin chronically over years and years, and he came in to see me in a clinic years ago, depressed. So in general, it may not be a great idea to prescribe medication for a patient who's chronically using drugs or alcohol. But in this particular patient, I felt comfortable doing it, and I prescribed him an antidepressant, and it seemed to be at least somewhat helpful. So rules are rules, guidelines are guidelines, but we want to go with what feels right to us ultimately. But of course, before we go with what feels right, we want to get enough information, have enough knowledge in order to make a reasonable decision. So we don't want to just out of habit go against the rules, but we want to take the rules with a grain of salt and be flexible, in my opinion. Another patient who stays in my mind is a patient who I was in a hospital on the East Coast working on an inpatient psychiatric ward. And this patient was from the West Coast, had taken a Greyhound bus to the East Coast and then was hospitalized psychiatrically, did not have quite enough money to get back. He needed $40 for a Greyhound bus to get back to the West Coast. And the hospital was not able to give him that $40, which seemed kind of strange to me because each day in the hospital costs many, many dollars, much more than $40. So I went ahead and gave that patient $40 of my money. And I think that may have been the only time I ever gave a patient that amount of money. I've given patients maybe on occasion, rarely, $1 or $2, like for a soda machine or something like that. But in this particular patient, I gave him $40. He took the Greyhound bus back to the West Coast. And then a while later, I got an envelope from him with the money back and a nice thank you note. So it's not something I would generally advise to give patients money, but again, use your judgment, and if it feels right, it may be reasonable. And we saved the hospital a good amount of money instead of having him wait days and days in the hospital in order to find a place for him to go. We were able to get him back to the West Coast. And another patient I'm thinking of is a patient who was a heroin user. He'd been in the hospital for a while, very depressed gentleman, did not want to be discharged. And I was about to go for a week to a conference, and he told me, "Doc, I don't feel I can cope outside the hospital. I really don't want to be discharged." So that's the message I gave for the doctor covering me for that week. But unfortunately, that doctor, when the doctor spoke to a supervisor about that patient in a weekly meeting, the patient ended up being discharged. And unfortunately then ended up overdosing on heroin, was admitted to the ICU in the hospital, and then unfortunately died. So that's something in hindsight that I feel sad about. And again, this was a gentleman who was being open with me that he did not feel that he could function outside the hospital, and unfortunately that was correct. And another patient, the last patient I'm going to talk about for today, is a patient who called me up maybe a few months ago and said that she was suicidal, and it sounded like she was somewhat on the edge, dangerous. And she promised me, though, on the phone to go to an emergency room. And I felt okay with that. I mean, not fully okay, because you never know. But I felt okay with that, and I trusted her instead of trying to call 911 on my own and making sure that she's taken to a hospital. She ended up going to the hospital on her own. And in hindsight, for our relationship, I think that was a good thing. Her knowing that I trusted her enough to let her go to the hospital on her own, and me knowing that I could trust her in that situation. Thank you.